Hello and welcome to COVID Conversations here on WNCU 90.7 FM, streaming on YouTube, Facebook, and Instagram. I'm your host, Kimberley Pierce Cartwright, News and Public Affairs Director here at WNCU 90.7 FM. And we're using the Zoom platform to talk about how COVID-19 is affecting our world. The COVID-19 crisis is hurting communities in this country, but the hurt is not equal. Data throughout the pandemic shows that communities of color, including children, are on the front lines of vulnerability. Here to talk about African Americans on the front line of COVID-19 for Black and Brown people 2 years into the pandemic is Dr. Michelle Cotton Laws. She is the Chief Experience Officer for the North Carolina Medical Society. And how are you today, Dr. Laws?
Hello, my friend. I am doing well, and I hope you are.
I'm doing as well as can be expected. We are always looking for friends to come and help us to break down the issue of COVID. And I'm so glad that you've taken time out. And this is not your first time, so it's not your first rodeo with this here. So I appreciate your time.
Oh, I'm honored to be here with you, Kimberly. Always excited whenever I get a call from you. So
very good. So first question, how does health equity look like? Or what does health equity look like in the fight against COVID-19 for Black and Brown people 2 years into this pandemic?
So let me start. That's a really good question. So let me start with how I define health equity, because there are different ways that people define it, different ways that people measure it, and different ways that people address it. So really, I think in a nutshell, you can think of health equity in several ways. One is, do people have the same access to care, access to medical care and medical treatment, regardless of where they live, and also regardless of their age, their socioeconomic status, which is an index of combining income and education levels. That's one measure of SES, socioeconomic status, and also without regard to the color of their skin, their race, or ethnicity. So access, and not equal access, but equitable access. And some people have seen the different graphics showing someone standing on the ground, someone standing on a cart, another cart that's a little taller, another cart that's a little taller, right? And they're the same height, but depending on, or not the same height, and depending on where they are, they can't see over the fence, right? So people have seen that very familiar and often used graphic. So what that suggests is that if there's a fence in the way and I'm taller, I may not need a stool to stand on, and I can still see over the fence. If I'm a little shorter, I might need a stool. If I'm shorter than that person, I might need double stools or boxes, right? So equity means that no matter what my disposition is, what my status is, I can still see over the wall. I can still go into a doctor's office and get quality care, no matter where I live. And that's what equity looks like. That I have access, no matter how much money I have, no matter where I live, whether it's a rural area, an urban area. And if we're talking about county, at the county level, whether it's a particular zip code within that county, I can still have access that's not blocked, where there aren't barriers to care. When we talk about COVID-19, which was is a public health pandemic, a medical health pandemic, it is important for us to look at those communities that don't have equitable access to care and don't have also equitable access to what I call other primary sources of capital: social capital, economic capital, and political capital. What does that mean? Economic capital, we know that's money. Social capital means a network of people that's sharing good information, a network of people that can help provide resources so that people can have access. to the care that they need, to the public health or the medical treatment that they need. And then political capital, believe it or not, is also important. Can I call my congressperson, or can I call my state representative or my local county commissioner or city council member and say, hey, we need a testing site, and get a testing site? So equity in the face of COVID for African Americans and also for Latinx or Hispanic, and we can't forget our American Indian population. Equity should look like any one of those, or any person representing those communities should be able to tap into the different forms of capital that I mentioned, or should be able to receive medical treatment and care if they need it. Not only medical treatment and care, but let's think about prevention. And one of the earlier guidances that was given at the onset of the pandemic was to, we shifted from working inside buildings 5 days a week, if you worked on a weekly basis like that, 8 hours a day, to working a hybrid or working from home. Not everybody was able to do that at the onset of the pandemic. And guess who wasn't? Guess who was most likely to work in essential positions or jobs? And I'm not talking about doctors or healthcare workers at the top level. I'm talking about the housekeepers of the hospitals. I'm talking about the food service workers of facilities like long-term care facilities or nursing facilities. They were most likely women, and they were most likely to be, compared to whites, most likely to be Black or Hispanic or Latinx, or depending where you live in the state, where there's a large, we call it indigenous, but in North Carolina, they prefer to be called American Indian population. So that's how it's impacted on the front end. Not only did they not have access to some of the capital coming in to the pandemic, but they were also most likely to have increased risk of exposure because they had to be out there in contact with people. Another way that it disparately impacted Black and Brown communities and American Indian communities in North Carolina, when we think about children. Schools shut down, they went to learning online, and many kids, one, if they lived in rural areas, had poor broadband connectivity access. So that impacted kids, and particularly from low income and in those areas who were most likely to be Black and Brown and American Indian population. That impacted them in a negative way in terms of lost learning time, right? And so when we think about the kids, they were impacted educationally. Most of those kids that lost a year or more of learning throughout this pandemic were African American and Black and Brown or Hispanic and Latinx kids and American Indian kids, especially those whose parents didn't have, they had one computer. And even though the schools may have given out laptops and so forth, they may not have had a good internet service. And when you think about the families that did have good internet service or could go to a second home, right? That was also an issue, right? So kids who got a chance, they weren't stuck inside the house, but they got a chance still to experience life outside of the house where they could go to their vacation home or something, right? So the impact on kids that were stuck in the home, they didn't have other options in terms of extracurricular activities or ways that they could decompress and de-stress. So this pandemic has had a major impact, and what health equity should look like as we're moving forward is now we know that there's been a great investment in expanding broadband across the state, especially in rural areas. So that's an equity issue, and that's addressing the gap there. We know that we stood up, or the state stood up, testing sites and vaccine sites to at least give people access to testing and vaccination. We also know that telehealth came online so that people didn't have to necessarily find a doctor in their community. They could now go online and have greater access to physicians to treat whatever the conditions were. that's what equity should look like, is us making accommodations and providing supports to people who coming into the pandemic were disproportionately impacted across social and economic indicators. So that's sort of, I hope that answers the question, what equity should look like. And also doctors recognizing, that they had to be culturally competent. And when we talk about mental health, which often used to not be talked about, but it's being talked about a great deal more than it was at the onset of the pandemic, but how they also had to be, trained and educated in trauma-informed care. A lot of trauma people have experienced, and particularly Black and Brown people have experienced a lot of trauma during this pandemic. Don't forget, when George Floyd happened, it was at the same time, around the same time that we announced, or that the governor declared a state of emergency in North Carolina, that COVID was now, we had moved into this emergency in our state. And so people have experienced a lot of trauma. And then after that, others have happened. People found out about Breonna Taylor, and then Andrew Brown happened. And so equity looks like providing access to care, mental and physical health care in communities without regard to the demographics of that community, including race, ethnicity, geographic location, socioeconomic income indicators.
So healthcare inequities have existed forever. So how has the conversation changed about inequity during COVID? Is it the same? Is it less? How has it changed, if at all?
That's a great question. I think it has changed in the sense that agencies, organizations, including state organizations, including healthcare systems, are being a little more intentional about how and when to address health equity issues as it relates to race and ethnicity in particular, as well as socioeconomic status and geographic location. So the good thing about COVID, but again, this happened, it happened at the same time that the nation was beginning to talk about diversity, equity, and inclusion as a result of the horrific killing of George Floyd. So let's not forget that. That was happening in the background. So that also pushed the conversation about equity forward. At the same time, we were learning across the country, and in North Carolina, we were no different, that the availability of resources, medical resources, public health resources, were not equitably distributed across the state. And so we started, under Secretary Mandy Cohen's leadership, started really intentionally looking at ways to increase access and to mitigate some of the harm that was being done disproportionately on HMPs, is what we call them, historically marginalized populations. And so I would say it's changed in the sense that there's more intention around how we address health equity issues, from a structural as well as from at a community level and at an interpersonal level as well.
So how do we put more pressures on the powers that be to turn some of these situations around? If you know it and you see it, and it's a part of communities across the state and the nation, then what has to happen to make all of that meld so that people do get the health care that they need, not only through COVID, but then through their everyday dealings and life?
Well, you said it in the question. How do we put more pressure? You put more pressure. And don't be afraid, one, to put the pressure on those powers that be who have the resources and who can make decisions. So that's policymakers, that's hospital administrators, that's public health, leaders. So everyone that has the resources or can make decisions about the distribution of resources, one, you hold them accountable, and you ask, How are these resources being distributed in my community? So people have to show up at meetings virtually. Many of them are still virtual, or they have or are hybrid. You can choose now. That's another good thing that's come out of this pandemic is you don't have to show up downtown at a city council meeting, but you can actually log in and you can submit questions and so forth. So one is to show up so that you do put pressure and don't take for granted the importance of investing in health. So there's a saying that your health is your wealth. If people are sick, if people are dying, which people of color, and particularly African Americans, all the way through the pandemic, with the exception of the Omicron variant, where African Americans were dying at a disproportionately higher rate than any other group. Hospitalizations were high among African American populations. Hispanic and Latinx communities the cases were higher, but not the deaths, right? So investing in healthcare should be a priority for every community and every family, because basically no one has been untouched, has made it out of this pandemic. And when we think untouched in some way, in a negative way, and especially if you're an African American, right, where you were more likely to die or more likely to have a family member that died or a friend who had a family member that died. So it should be a priority now on all of our radars: health and wellness of children, as well as health and wellness of adults and our seniors. We cannot forget our seniors who also suffered in different ways. We saw increases in loneliness among seniors, increases in mental health, like depression. And when you think about it, going back to the social capital, the social network, when churches close their doors, that block access or shut down access to a critical social network for our seniors. Just think about it. How did they socialize? At church. They look forward to being picked up by the church band or a family member or driving themselves to church every Sunday and going to midweek Bible study, right? And being able to reach out and interact in their, little groups, right? The golden mothers circle and sisters of this, that, and the other, right? And so when all of that shut down, adding to the lack of access in terms of broadband, especially our seniors in our rural areas, some of them hadn't turned on a computer since they retired 20 years ago, right? And so, and their phones, many of them still had flip phones, and their phones weren't connected to internet, and they didn't have access. So thinking about our seniors, health should be a priority. Health and wellness, it's a priority of the North Carolina Medical Society, creating a healthier North Carolina. And we represent the physicians and the physicians' assistants in the state. So I think, how do you demand, that's what you do. You put the pressure on. And hold them accountable and make sure that healthcare is a priority for them as they are legislating, and also for the candidates that are running for office. Healthcare has got to be a priority. Health outcomes have got to be a priority, and health equity has got to be at the center of those priorities.
Okay, Dr. Michelle Cotton Laws is Chief Experience Officer for the North Carolina Medical Society. Dr. Laws, thank you so much for your time today. It's been very enlightening, as always.
Thank you. It's been a pleasure. And, this is a conversation that we have to have. And I'm hoping that at some point we will talk about the mental health impact, the behavioral health impact. A lot of times, when people talk about COVID, again, like I said, it's from a public health perspective or medical, clinical perspective. But we've got to talk about integrated health care, which is important, and especially the behavioral health side of that. Because now when we think about people who've lost their homes, lost their jobs, disproportionately impacting African Americans, Hispanic and Latino, and young people. Those are the ones that have not gone back into the workforce, not because they don't want to, but because of structural and other factors that are keeping them out. So they're less likely to be able to pay their rent. And when you don't pay your rent or your mortgage, you get kicked out, right? And so the housing crisis, the academic or educational crisis, and the economic crisis are disproportionately impacting Black and Brown people and American Indians. And we've got to continue the conversation. This is just the beginning, and I appreciate you having me on to have that.
Well, come back really soon, because all of those issues are very important. People need to know, and that's what COVID Conversations is all about, informing our community. So thank you once again for your time. Great to see you, and you are on top of the eyeglass game.
Oh, you as well. It's always an honor to say yes.
Yes. Yes. I want to thank you, audience, for watching via YouTube and Facebook and Instagram, as well as listening on WNCU 90.7 FM. We want you to like us. We want you to follow us. And we want you to go onto Facebook for all of our archive shows. Again, thank you so much. I'm Kimberly Pierce Cartwright, your host for COVID Conversations here on WNCU 90.7 FM.